what a great crowd. Thank you so much for coming out today. I'm Rebecca Cerise, and I'm one of the members of Healthcare for All Y'all, which is the lead organization behind tonight's event, and I'll be your host for what I hope will be an engaging and interesting evening. Healthcare for All Y'all is a group of concerned citizens that are working to educate people and elected officials about how an improved Medicare for All system can fix our healthcare woes. Please like us on Facebook or sign up for our 5-minute action. At your table and around, you'll see the little URLs, so you can do it on your phones. We have like 5-minute actions that we send out once a week, and it's just articles or videos about this topic. There's also a URL to fill out an evaluation form, because we really want to know how you felt about this event. So we just have a couple questions, and it really helps us to put on better events in the future. So I would like to take a moment to thank our co-sponsors of this event, Jonathan Koch, Dr. Koch, and his organization Healthcare for All NC, which is the local affiliate of PNHP, and the Coalition for Healthcare of North Carolina, in particular Patty Reiser, Mary White, Dale Herman, and Richard Paddock. I also want to thank the United Church of Chapel Hill for letting us use this wonderful space, meeting space, with a special shout out to Rennie Orr and Bill Murray. Lastly, I want to thank my fellow Healthcare for All Y'all family, Katrina, Erica, Beth, Marianne, Nina, Gary, Jackie, without which we wouldn't be having this event. And I want to also thank Dan for filming for me tonight, and we'll be able to make it available on YouTube for folks. We're also live streaming on Facebook, so if you want to share the event with other people, you can find the Facebook stream at our Healthcare for All Y'all Facebook page. There's 2 elected officials, I think, in the audience, and I want to thank you, Verla and Catherine Ferguson, for coming to the event. Really thankful. So on to the festivities. I can only guess that you're here because, like me, you understand that our healthcare system is not quite working for all of us. The corporations are siphoning healthcare dollars away from care and into their own pockets, and those elected officials who are supposed to represent us, but instead are taking lobbying dollars in large amounts, have no interest in changing the status quo, so it's really on us. We must empower ourselves with information about the inherent problems in our system and the solutions that can transform it. We must then use that knowledge to fight for a healthcare system that will work for all of us and also effectively control costs. That's what the second half of this event will get. We'll get into that. But before I introduce our expert for the evening, I want to leave you with this thought. 59% of the revenue for the 5 largest private for-profit insurance companies, Aetna, Humana, Cigna, United Healthcare, and Anthem, came from Medicare and Medicaid in 2016. That means our public dollars. Also note that does not include cost-sharing subsidies or government employee insurance. Can you guess how much those 5 CEOs were paid that same year? $129 million. Do Aetna, Humana, Cigna, United Healthcare, or Anthem actually add any value to our care? Keep that in mind keep that thought in your mind over the evening. So we're running on a tight schedule, so please, on the back of your programs, which are on the table, there's a place to jot down questions, and there should be some pens on the table. So we're going to do a question and answer all at the end of Dr. Weisbart's presentation. So now I'm thrilled to introduce tonight's speaker, Dr. Ed Weisbart. There's a slightly longer bio on the program, so this will just be a quick and dirty one. As a family physician, former chief medical officer of Express Scripts, which is a pharmacy benefits manager, and the president of Missouri chapter of PNHP, Dr. Weisbart is an expert on this subject from very different angles. Let's give him a warm welcome.
I'm actually thrilled to be here talking with y'all, with all y'all. I love that phrase. So, we're going to run through some of the information about Medicare for All, but I honestly don't care about Medicare for All, y'all. That's not what wakes me up and gets me excited in the morning. What I care about, I'll bet, is actually the same thing that y'all care about. I care about these patients that are having these crazy, terrible problems. This guy that I saw, diabetic, for whom I prescribed insulin, who came back a month later, no better. And I said, why are you no better? Are you taking did you get your insulin? Yes, I did. Are you taking it? Well, I'm taking it a little bit every other day rather than a full dose twice a day as he was instructed, because that's all he can afford. And so then I get to watch this guy get sicker and sicker and lose his kidney function, and then he goes on to dialysis, right? And he goes on to dialysis, and then of course he has Medicare and he has health care coverage. So I would much rather treat these people ahead of time rather than wait till they get desperate. So that's what excites me. That's why I'm here, because I hate seeing situations fall through my fingers when we know what they need. So that's why I'm here. You heard I'm a physician, as you probably noticed. That's my core ethos of who I am, and I got roped into sort of the business community and then more recently into political advocacy. So I practiced family medicine in Chicago for 20 years, delivering babies and stuff, and I moved to St. Louis in 2003 and started volunteering at safety net clinics. So I still do that almost every Friday when I'm not in North Carolina. So I see patients at least once a week. Now, I moved to St. Louis to work at Express Scripts, which is, as you heard, a pharmacy benefit management company. And the reason I'm telling you about Express Scripts is because that influenced my philosophy quite a bit. It made me realize no matter how good your ideas are, if you don't have a business plan, if it doesn't make economic sense, there's probably something wrong with the idea, and we're not going to make it happen. So what persuaded me to focus on this issue in the way that I do is because I became persuaded that this does make business sense, and I'll walk you through that line of reasoning. That's essentially my core interest, frankly. And then, so I retired from Express Scripts in 2010 and put together the Missouri chapter of this group you heard of, Physicians for a National Health Program. We're almost all volunteers. I'm a volunteer. I'm not paid to be here. Everybody that you've heard from is volunteering. We don't have anything to sell other than philosophy, I guess. So we just think it's incredibly important. Our organization spans the country and is growing. We have 21,000 members, and we think Medicare for All is the most prudent answer. So that's me. So the question is, why Medicare for all? I mean, there are many other ways you could think about it. Why Medicare? What's so great about Medicare? So I know you all know there's a lot of good things about Medicare. I'm not going to belabor all of it. Here's one thing. Harry Truman was the first Medicare member, and he became a member less than a year after the bill was signed. So Medicare, without computers, was implemented fully in less than a year. So it's a simple solution is the point. Medicare is actually really simple, especially when you think about the alternatives. And it's rescued seniors from poverty, and it's done all kinds of wonderful things. But there's three specific things that I think are often not really recognized that are quite important about Medicare. The first is that it puts y'all, all y'all, in control of your health care. The second thing is it's much less waste, and then the last thing is it actually extends lives. So let's unpack this a little bit. It puts you in control. And to explain that, let me introduce you to my mother-in-law. There she is. And I happen to have one of the world's best mother-in-laws. I'll spare you her life story, but it's really cool. And she's a lot like my wife, only older, so it's a good thing that I like, anyway, she's a remarkable person. And for those of you HIPAA cops here, I have her permission to tell you this story. And the story involves my wife's health a little bit too, and I have her permission too, so calm down, you HIPAA cops. Anyway, so Ma lives in Florida. She's in her late 80s now, and she has a rare genetic disease in her heart. Hokum, if you care. She has a rare genetic disease in her heart. And it's one of these things that doesn't turn up until you're in your mid-70s or so, typically. And she developed signs of it, and it will kill you, frankly. And she was getting pretty sick from this, so she wanted to get it treated. It turns out it is actually rare, and there are only 3 places in the country that focus on treating this uncommon thing. And one of them happens to be in St. Louis. So that's where, there's none in Florida, nowhere near where she is. So there's one in St. Louis. So she has Medicare, and she has a supplement. So she has traditional Medicare because she's worked forever, and she's paid her premiums, her taxes or what have you. And she bought a supplement because Medicare has deductibles and copays, and so she bought a supplement. She did not buy into an Advantage program, which is completely different. So Medicare and a supplement, the supplement just supplements the gaps in Medicare. An Advantage program actually is Medicare paying an insurance company to give you the kind of crummy insurance, frankly, that I have today. So if you have an Advantage program, you have to deal with directories and all of that stuff. So she doesn't have that. She has Medicare and a supplement. And as a result, she could come to St. Louis and not have to worry whether it's in network or not. She didn't have to pay a penny other than what she's paid in taxes and her premium for Part B and that kind of stuff. So she didn't have to pay literally a penny. Now, it may turn out that my wife has this. I hope she doesn't, but she has some suggestive symptoms of it. She's been tested, it's indeterminate. But let's say Cindy, my wife, had this and had to go to Pittsburgh. Well, we have insurance. I pay $2,000 a month for my Cigna insurance through the marketplace, $2,000 a month, and that comes with a $6,000 individual, $12,000 family deductible. So basically, that's for the two of us. So basically, I have to pay $30,000 a year before my insurance activates. So let's say Cindy has to go to Pittsburgh, and that wouldn't be in our network. So that cost about $100,000 for my mother-in-law here. So that $100,000 for Cindy to go to Pittsburgh, that would be on me, on Cindy and me. Well, most Americans can't come up with $1,000 to pay for an unexpected medical emergency, medical problem. Nobody can come, very few people can come up with $100,000. So, my mother-in-law would be dead right now without that. And I don't know, it's a terrible thing to have to know something's wrong, to know that there's a treatable thing for it, and, not have the money to treat it. So if you talk about messing up Medicare, you have to deal with that. And trust me, you don't want to deal. We like the other mob a lot better. So is it really true that you can go to anybody if you have Medicare? How do the numbers of that look? There's almost 700,000 physicians in practice in the United States, and there are actually thousands, 9,500 physicians in the United States who do not accept Medicare. So if someone says, Medicare, really, there's thousands of doctors who won't even take it. How good can it be? They're saying the truth, but there are hundreds of thousands who do take Medicare. And if you do the arithmetic, it's more than 98% of physicians do take Medicare today. So in other words, if you have Medicare, not Advantage, that's a whole different thing. If you have Medicare and maybe a supplement, you can go to any doctor, virtually any doctor, to virtually any hospital, and your decisions about your health care are what determine your health care. That's not true for me with Cigna today. So that's a really important feature of Medicare. Another important feature is it's the best way I know of to stop wasting money. So look at this. This is the published overhead of the insurance companies, and if you care, it's actually medical loss ratio from 100% if you care about that stuff. Any of my charts that have numbers on them, as this will shortly, there's a footnote down at the bottom there, and it's too small for you to read. It's just there in case you really have to know where my data comes from. I can read it to you right now. It's a public domain, peer-reviewed kind of source for all of my data. So anyway, here's SEC filings for the larger insurance companies, and as you can see, they have 15 to 20% overhead compared to 2% overhead for Medicare, all in. That's with the IRS staff that collect the Medicare taxes and the brick and mortar and the GAO percentage of the GAO. It's all in. And that makes sense, right? Because you heard about the salaries a few minutes ago that Medicare doesn't have. They don't have people making more than government scale, and yet they're working pretty well. They don't pay for advertisements on the television. They don't pay for a lot of things that they don't need because once you turn 65, you get it, so they don't have to advertise to you. The ads on television for Medicare are not for Medicare. They're for an Advantage program. Again, a completely different critter. So it's a much lower level of overhead. In other words, it's more efficient in my mind. We stop wasting a lot of money with that. And then the last piece of this segment is to talk about how it makes us healthier. And I promise you, this is my wonkiest chart. So bear with me on this. It's incredibly important, but it's going to be a minute for you to kind of understand what this is showing. and I apologize for that, but it's just so important that I want you to see this. So here's our, come on, here we go. Here's the United States compared to 17 other peer nations, Australia, Austria, Finland, Ireland, I can read the list to you if you want. Compared to 17 other peer nations, our mortality rate, or I think of it as our remaining life expectancy, by age. So you know that our life expectancy here is 2 or 3 years shorter than almost any other modern nation. Despite the fact that we pay double what they spend, our life expectancies are 2 or 3 years shorter. So the first part of this chart won't surprise you. Here we are. There's a 4-year-old American compared to 4-year-olds elsewhere in the modern world. There's me. There's a 64-year-old American as compared to 64-year-olds elsewhere in the world. And then there's my mother-in-law. There's an 88-year-old American, I believe she is, compared to 88-year-olds elsewhere in the modern world. So you know we're going to be the lowest part of this chart because we're, frankly, the worst at this. So there we are. There's men and women in the United States scoring the worst in terms of life expectancy or mortality rate compared to 17 other nations. That you knew. You didn't need me here for that. Here's what I'll bet you didn't know, this. Did you know that? We turn 65, and somebody a couple days ago said, health begins when we're 65. We turn 65, and all of a sudden, well, not all of a sudden, but pretty quickly, our life expectancies become the best in the world, so that the most senior among us actually have better life expectancies than virtually anybody else in the world. Isn't that extraordinary? So that says to me a couple of important things. First, it says we have many of the world's best doctors, hospitals, nurses, all of that stuff. You can't be the best in the world at healthcare without the best healthcare in the world. We obviously do, or this couldn't happen. It also means that we have the best healthcare finance system in the world, because that's what changes. The problem isn't our structure, the problem is we don't let everybody into it. So we should be hugely proud of our healthcare delivery system, and we should be hugely proud of Medicare, because I think this speaks for itself, that we should be, it's ours, and we did a great job with it for 52 years. So what's Medicare for all? Kind of a complicated term. It's actually really simple. So let's walk through this. So here's us on the left there, and then there's all the stuff we want. We want doctors and hospitals and all that good stuff. And in between us, of course, is the money, right? So the money is managed by payers. So here's one payer, the United States government. We pay our taxes, and then they pay for the health care for the military, the post office. They pay most of Medicare. They pay half of Medicaid. They're a payer. We pay them. They pay for that stuff. So do states. They pay half of Medicaid, state employees. So are cities, so are schools, so are the businesses, and so are all the insurance companies. So this is an incredibly complicated system, and complexity is the enemy of quality. This is complicated. It's also expensive to maintain all of this. Something on the order of 31% of what we spend on healthcare goes to prop this up. So my $2,000 a month check includes $600 a month just to sustain the insurance industry. That makes me sick. So it's expensive, it's inherently compromised in quality, and there's, of course, gaps. So that's the way it works today, complicated. Compare that to what we could do, just one payer. Get it? Now you know what the phrase single payer means. One payer instead of the thousands of them that we have. And I just think that the most prudent way to do that is through improving Medicare and giving that to everybody. So there are other ways you could set it up, but this seems to be the most sensible way for the United States. So you heard me say improved Medicare a few times. What does that mean? Improved Medicare. What specifically? So there's a few things, but there's two main things that really need to be improved in Medicare. One is Medicare simply doesn't cover some things that, frankly, everybody, and certainly seniors, should have. Medicare doesn't cover dentistry. Do we really want to tell Americans that they can't go to a dentist? It doesn't cover glasses. Do we really want people driving around who can't see? It doesn't cover hearing aids. Maybe that's why, maybe nobody wants to listen to me, I don't know. But it doesn't cover about 15 or 20 things that are really important to have. And so when we say improved Medicare, one of the things we mean is to put those gaps in the benefits into Medicare. And the other problem, bigger problem with Medicare is that it has pretty significant copays and deductibles and such. And those are actually barriers to healthcare. So seniors either buy a supplement if they can, like as my mother-in-law did, or they'll go into an Advantage program despite the networks and the problems, just because they can't bear the expense of the exposure of not having improved Medicare. And then a third of seniors don't have any of those things, they're just exposed. So when we say improved Medicare, we mean these two things mainly. We mean fixing the benefits, giving dentistry and all that to be part of it, and then secondly, getting rid of the copays and deductibles for the most part. So that's improved, that's what we mean by improved. And then expanding it to everybody, giving it to Congress, giving it to President Trump, giving it to everybody, giving it to teachers, giving it to coal miners, giving it to kids. If you gave it to kids, we wouldn't have to have these periodic fights over renewing CHIP. Giving it to you, giving it to everybody in the room, so that then you would have dentistry covered. Hooray. You know, giving it to low-income folks, so then we don't have to have these horrendous fights about Medicaid expansion. Giving it to everybody. And that's not just to be nice, I mean, which I guess it is, but that's not really the reason why it's so important to have everybody in the program. The reasons it's so important is, you remember those big scary red bars of the overhead of the insurance companies, the big looming red bars? The only way to make that go away is to move us all into that nice little happy green spot. That's the Medicare overhead of 2%. Really important. That's the best way to get the savings, is to do that. The second thing is it creates the largest risk pool. So if you're a business owner and you have, let's say, 200 employees, and one of them gets a bad form of hemophilia, that one employee may cost more than $1 million in hemophilia factor. Well, that means that your premiums as an employer the next year are going to be through the roof. And employers can't predict the cost of their health care. Employers are often telling me that they're seeing their health insurance premiums going up by $4 an hour per employee, which means they can't negotiate for wages or any of the other things they want to do. So it's really important to have a large risk pool. That makes it more predictable, and it's the only way to leverage our size. And then the last thing is, if everybody is in this program, if the Congress people are in the program, it's their program too. They don't have a separate FEB program that lets them have a different kind of health care. They need to be in the same program that we're in, and that means that they would want to make it as good as they want it to be too. And that would mean if they tried to do something to destroy it or hurt it or weaken it, they'd be weakening their own health care, the health care for their families and their kids and their neighbors. So it really makes the program more resistant to legislative damage. So there's a lot of reasons, not just it's nice, there's a lot of important reasons that we need to have everyone into the same program. If you did that, of course, then there would no longer be a need for a supplement, and there would be no need for a Medicare Part C, the Advantage programs. Those things would essentially disappear. It's also incredibly important. So I think of this as a market solution, and let me explain what I mean by that. Healthcare organized around the world is a long topic, but I'm going to overly simplify it into one of three ways that healthcare is organized. Over here, to your far left, is a national health service. So this is where you pay your taxes, and then the government owns the delivery system. The government owns the brick and mortar of the hospitals and the clinics. They may build the clinic. They may take over the clinic, as they've done in Cuba. The government owns the means of production, right? And that's the definition of socialism. They hire the physicians, they fire the physicians, they own the means of production. So that's socialized medicine, that's the VA. It actually gets spectacular outcomes in many places, so I don't mean any aspersion to it, but that's literally socialized medicine. It exists, and it works well in many places. Over here to your far right is a different model. I call it Wild Wild West health insurance. I don't know what to call it, but this is our model, so I'm not going to belabor it. You're familiar with it. My point is that these are both extreme ways to set up a healthcare finance solution. So that's extreme, works pretty well, not good or bad. That's extreme in the sense that it's as far into healthcare as a government can go. Well, since there's nothing further you can do, that's, in my mind, by definition, an extreme way to set it up. Good or bad, it's an extreme way. This is also extreme because nobody else is doing this. when you're the only one doing something a certain way, maybe you've figured out the best way, good or bad, it's extreme. There's nobody else who's settled on this solution. And the reason I'm framing it like this is because I believe that smack dab in the middle is a nice conservative solution. A nice conservative solution. You like that phrase? So it's a national health insurance. So it's publicly funded, you pay your taxes, but it's privately delivered. Doctors can be in solo practice, in group practice, work for a hospital. We could talk more if you like at the Q&A about the implications for physicians, but it's a private delivery. Government is not doing the delivery. It's not socialism, and I actually think of it as a free market solution. So this is how Medicare works. This is how Canada's healthcare system works. And the reason I think of this as a market solution is think of what the market today is doing to healthcare. The market today is making me compete against other physicians for the most lucrative insurance contracts that I can get. So the typical primary care physician will see something like 4,000 patients a year, something like that. If I can spend an hour or two, or have my staff spend an hour or two negotiating for a contract that gives me $5 more per visit, that's $20,000 more per year for several years going forward for the hour or two of negotiating. That's the game. That's the game. And so then when you come into my office and there's a sign saying, I no longer take insurance product XYZ, that's because you lose. You know, you're not worth enough money to me to want to keep on seeing you. That's what that means. That makes me want to, that's not right, I don't think. But that's the market today. If I have to tell, 20 of my patients that I can't see them anymore because of their insurance, that's one thing. I'll get better paying patients. So that's what the market is doing today to healthcare. Instead, under a Medicare for All program, everyone in the country would be worth the same amount of money to me. I wouldn't have to assess what you're worth before I let you into my practice. And so the money would follow you directly. If you decided to come see me, I would get paid for that. If I've annoyed you or something and you want to go see somebody else, you would go see somebody else and I would stop getting the money that's following you. So that's nobody would be telling you that you have to see me or that you can't see me as they can today. So that's a much better use of the market, in my mind, having it drive you to be really controlling how busy people are. And as you know, there's two bills in the legislature, one in the House and one in the Senate. And we can talk afterwards if you want about the differences. There are some important differences. But let's walk through just a little bit of the economics of them. Very similar. So it happens that there are 25 studies, literally, I counted them, and there are probably more that I've not yet found. There are literally 25 studies from different economists, different regions, different assumptions, different everythings, 25 that come to the same conclusion, that there's new costs, but the new savings are at least as big, if not bigger. Most of them say we actually save more. So 25. There are two that come to a somewhat different conclusion, and I'm going to explain that to you because you really need to understand it, and we'll get to that. But there's 25 that come to this. I'm going to walk you through one at a very high level. So this one says, of course, it's from the University of Massachusetts. Of course, there's new costs, but there's new savings, and the new savings are bigger. So the new costs, we'd have to pay doctors the same to taking care of Medicaid patients. Today, doctors are paid a fraction of what they get paid for any other patient, and that's why most Medicaid patients find it very difficult to find a doctor who will take care of them because, you're not worth much to us. So financially, so it's a problem, and that's not right. So there's a cost to paying more for a Medicaid patient to see a doctor, and that's how much. There's also a cost for providing insurance to those who are today without insurance. That's how much. And then everybody would start doing stuff, right? I'd go to the dentist. Y'all would go to the dentist. You'd get glasses. We would do things that we actually want Americans to be able to go do, right? We want people to be able to do that, but there is, of course, a cost to that. Okay, so I said there were two studies that were kind of goofy, and one of them, the one that was most prominently in the USA and the USA Today and the Wall Street Journal and all that stuff in 2016, in the summer, right before the general election, it actually just stopped here. It actually just stopped here. And it said, are you crazy? Of course, we'd like to do that, but look at the billions of dollars we'd add to the debt. Well, we can disagree about philosophy and politics and strategy and tactics and all that, But anybody who's presenting a study to you that only looks at costs and ignores any savings, well, that's just manipulatively misleading us on purpose. So what are the new savings that you have to consider? First is it's actually, of course, cheaper for the government to administer one program instead of dozens of programs. Okay, not very much because they've only got a 2% overhead, and they would be a bigger program, so there's not much savings, but there's something there. Of course, Health Insurance Administration would, by and large, be a big savings because we wouldn't have to do that. We would have a huge savings to doctors and hospitals. The United States today has about as many, a little more people working in hospital-based billing and insurance-related activities than we have beds. Some hospitals have more, some have fewer, but we actually have more people working in billing and insurance activities than we have beds in the hospital. So the average hospital in the United States could put somebody full-time at the foot of every bed from billing, not from nursing, and have a department left over. That's really expensive. Toronto General, on the other hand, has 3 people who work in billing. And one of those 3 work on Americans who came over the border. So that's incredibly wasteful. And then, of course, you have to let Medicare negotiate the prices of drugs and devices. So that's the other flaw in the other study, which is that if you looked in there, they would say that the government would save nothing from negotiating the prices of drugs and devices. That's just not right. I mean, we can talk more about that topic if you want, but that's just not right. So the reason it's so important for you to understand these 2 flaws is because I don't know who's doing it, but somebody in the year 2020 is going to release a 3rd such study. And it's going to say, you crazy people, we can't possibly afford it. I don't know who's going to do it. Somebody's going to do that, though. You know it's going to come out right before the general election. You know it's going to happen. And you need to be able to look at it and go, well, okay, new costs. How much are they saying for the savings? Oh, they didn't, did they? Oh, well, that's a problem. Okay, well, they said savings. How much did they save from negotiating drugs? Oh, they didn't. Well, and there might be something different that they would do wrong. But the point is, try to be a critical judge of that when you hear it's going to happen. You just know it's going to. So learn from that. Anyway, last piece of this sort of background-ish stuff is to compare us versus Canada. So and that's important because when you talk about a system that's similar to Canada's, oftentimes people will say, well, Canada. I mean, it's bigger. It's got rivers. It's not got the genetic diversity that we have, which I think is a code word for something more racist that they would want to say. I don't know. They say all kinds of crazy things to explain why we can't really compare the United States with Canada. Well, can we? If you look back to 1971, we were the same, actually. Our healthcare costs were the same percentage of our GDP and on the same trends as Canadians. And our life expectancies were within a few months of each other. And then, in 1973, President Nixon signed into law the HMO Act, supposedly to reduce the cost of health care. And in 1971, as it turns out, is the year that Canada fully implemented their Medicare program across the country. They call it Medicare. We took that word from them. So they fully implemented Medicare. So in other words, we were the same, and then we made national policy decisions that were at odds with each other. We chose managed care. We created managed care, and they chose Medicare for all. So what happened? How did that work out? Here's our healthcare cost. It's a percentage of GDP, the relentless climb up to 19% now. And then there's the HMO Act to lower the cost of healthcare. Hard to see. And then here's Canada's data. Here's Canada's data. So we were the same, following the same curve, and as soon as these policy decisions forked in the road, the curves changed, and now they spend half of what we spend. And life expectancy, this data only goes back to 1979, and I apologize for that, but in 1979, they were already living 1 year longer than we were, and now they live 3 years longer than we do. They live 3 years longer than we do. So they spend half of what we spend, they live 3 years longer, and it's all happened since the policy decision was made. So how is it looking around the country? What's happening in the country politically? So here's an interesting question. It is the responsibility of the federal government to make sure that all Americans have health coverage. This isn't the question of Medicare for all. This is the question of, really, should the federal government be involved in health care? Is it the federal government's job to make sure everybody has health coverage? Is that really the federal government's job? Well, if you ask people in 2013, most Americans said no, it's not. In 2013, 60% of Americans said it is not the job of the federal government to make sure that we all have access to health care. They said no, 60%. And then it changed. I think with the Affordable Care Act, people started thinking differently about it a bit. And now, 60%. We've flipped this. It's gone from no to yes. Most Americans now say, you know, the federal government should make sure everybody has health coverage. If you go by political party, this is specifically about Medicare for all. If you ask about should we expand Medicare to everybody, not a big surprise. The Democrats, 3/4 of Democrats say yes. That's not the surprise. The surprise is 46% of Republicans say yes. 46% of Republicans. And yet not one Republican legislator has co-sponsored the bills that would do this. So when we think it's hopeless, when we think that the country just doesn't get this, and that's not actually true. Almost everybody in the country gets this. We've won that fight. We've won that fight. It's about retaking our democracy. It's about tribalism. It's about other things. It's not this up. We've won this fight. They get this. Almost half of Republicans agree. And if you look at the bill in the legislature, in the House, the bill was introduced in 2003 to 38 co-sponsors and gradually became more popular. So that in 2008, it was actually the most popular health care reform bill that we've had. And then, of course, the ACA was passed, and a lot of the folks who were advocating or co-sponsoring the bill kind of moved their attention over towards protecting and such for the Affordable Care Act. Well, the last year or so, this has changed. We've crossed a watershed, a Rubicon, I guess. It's still only Democrats, although I would like somebody to point out what it is I've said tonight that's actually partisan, because I don't think there is anything. But it's only Democrats, so I think it's about tribalism. So it's a majority of the Democrats in the House. And in the Senate, now there are 17 Democratic, no Republican yet, co-sponsors of the bill in the Senate. And it's thought to include every one of the Democrats in the Senate who is likely to run for president in 2020. So think about that. 5 years ago, most Americans said, this is not the role of the government. 5 years ago, most Americans said, this is not the role of the government. And today, it's table stakes if you want to run for president in 2020 on one of the major parties. Huge. Have we passed it? No, but oh my gosh, we've come a long way in just 5 years. And I think it's this groundswell of support for this nice, simple solution is why we're seeing these fairly complicated, I think of them as diversionary suggestions. So there's now proposals for things called Medicare Extra, Medicare X, Medicare options, this, that, and the other thing. And some of them have some real value, but they fragment us from the real core issue of a nice, simple, prudent, American-built solution. Just fix Medicare in those two simple ways and give that to everybody. So you should join the local organizations, and you should join our national thing, and you should get onto our Facebook page and follow our tweets and stuff. And you don't have to be a doctor to be in Physicians for a National Health Program. I think membership is like $50 a month, $50 a year. Yes. Or you can just sign up for our emails and stuff, but stay in touch.